presentation. Okay, perfect. Okay, welcome everybody. Hope you all know well. My name is Ridaa and I'm a 5th-year med student, and I'll basically be doing actually 2 presentations. The first one is on the fundamentals of pathology, and the next one is the fundamentals of immunology. Okay, if you have any questions during the presentation, you can put up your hand, you can unmute yourselves and ask any questions if you have. Okay. So without any further ado, we're going to start with, okay, so firstly, pathology. What is pathology? Pathology is basically the study of diseases. So in first year, you were taught on basically on the normal body. Going to second year, you're basically going to do now the study of diseases and how diseases occur. So we basically start from a cellular level. We're going to start with cellular injury, okay? So let's speak about cellular adaptations, right? So reversible changes, cellular adaptations are reversible changes that can be either physiological or pathological, okay? So if a cell, for example, if a cell injury, right? For example, a uterine enlargement during pregnancy, that's a physiological because it's the body's physiology, a normal process. Pathological, for example, myocardial hypertrophy, secondary to systemic hypertension. So there's a certain disease which leads to a change in the size of the cells, which leads to a change in the tissues, which leads to a change in the actual organ, which will affect the physiology of the and how the organ will actually function. Okay. So if the stress is persistent or excessive, adaptations can then progress to a cell injury. Okay. For example, if you have left ventricular hypertrophy in your heart, if you have the hypertrophy of the muscle, it can lead to myocardial injury, which is a decrease in the blood supply to the heart, which then can lead to heart failure. Okay, so what is hypertrophy? Hypertrophy is basically an increase in the size of the cells, but what is actually happening is that there's an increase in structural proteins and organelles. Okay, an example of that is cardiac hypertrophy. Hyperplasia is plasia, many, right? So that's many, that's increase in the number of cells, okay? And it is described as a controlled proliferation of stem cells and differentiated cells. The controlled proliferation is very important because the opposite of uncontrolled proliferation is called neoplasia or cancer. So cancer is like uncontrolled division of cells, okay? But hyperplasia is benign. It's basically harmless. For example, benign prostatic hyperplasia, that's increase in the number of cells of your prostate cells, okay? Excessive stimulation can lead to a pathologic hyperplasia. For example, endometrial hyperplasia, which can progress to a dysplasia and then cancer. Okay, okay. Atrophy. So what is atrophy? So A means like opposite or against, small. So it decreases. It means a decrease in the tissue mass due to a decrease in the size. Okay. And or number of cells. So it's a decrease not only in size but also the number of cells. Okay. Apoptosis is a decrease in the number of cells, but a decrease in the size and number of cells is basically like atrophy. It's like the umbrella body. Okay. Causes of atrophy include disuse. So if you don't use a certain part of your body, denervation, a decrease in the nerve supply to that particular organ or tissue, loss of blood supply, loss of hormonal stimulation, and also poor nutrition. So if you're not getting enough vitamins to maintain that proteins, because proteins is protein for protein synthesis and all of that for growth of cells. Okay. What is metaplasia? Now, I always got confused between metaplasia and dysplasia. Okay. Now, meta, For metaplasia, it's the reprogramming of cells. And this, for this, think of disordered, okay? So metaplasia is the reprogram. Metamorphosis, to metamorphosize is to change, okay? To reprogram. So it's the reprogramming of stem cells, which leads to the replacement of one cell type by another that can adapt to a new stress, okay? So it's that morphology, meta change of that particular cell, okay? And it's all for adaptations to adapt to a certain exposure. For example, exposure to an irritant, such as gastric acid, leads to barred esophagus, or for example, in your lungs, when you smoke tobacco, the respiratory ciliated clammy epithelium is replaced by stratified squamous epithelium, but that you learn more in the respiratory system, okay? Now, it's very important to understand that metaplasia leads to a dysplasia, okay, which is a malignant transformation with a persistent insult, okay? For example, the barred esophagus can lead to esophageal adenocarcinoma. So it's almost like it's going from, yeah, okay? Metaplasia of connective tissue can also occur, okay? So for the, if it occurs in the connective tissue, example of that is myositis esophagus in the bone, the formation of bone within muscle after trauma, okay? Dysplasia is disordered pre-cancerous epithelial cell growth. It's not considered a true adaptive response, okay? But what are the characteristics? It's characterized by a loss of uniformity of cell size and shape, and that's another word for that is called pleomorphism, okay? There's a loss of tissue orientation. There's nuclear changes, so there's an increase in nuclear to cytoplasmic ratio and chromatin. There's for mild and moderate dysplasias may regress with alleviation of the inciting cause. Okay, so if you alleviate the actual cause, the mild and moderate dysplasias can regress, but if there's severe dysplasias, it can become irreversible and it can progress to a carcinoma, okay, which is obviously bad, right? Very poor prognosis. And always remember that a dysplasia is preceded by persistent metaplasia or a pathological hyperplasia, okay? So moving on to the next slide. Okay, so this is basically just a summary of everything which I just said. So this is your normal cell. If you have hyperplasia, increase in the plasia number. Hypertrophy, I think of it as atrophy. If you win a trophy is big, so increase in the size of the cells. Atrophy, obviously, A for against going down, decrease in the size of the cells. And inability to adapt can lead to irreversible injury. And irreversible injury is what we call necrosis. And necrosis is obviously basically damage to that particular tissue. And apoptosis is the death of that tissue, okay? For the normal cells, if there's severe stress or severe injury, it can lead to necrosis or apoptosis as well, okay? Here at the bottom, we have normal cells. So you get a neoplasia. Neo means new, right? So there's a change. There's a new cell type and new cell structure which forms because of a certain whatever stress or cause it was. The metaplasia, right? Meta change in the cell type, and the dysplasia is change in cell structure. And then obviously your dysplasia and metaplasia can lead to a neoplasia, okay? And a neoplasia is basically cancer, right? It's basically cancer, and it can either be harmful, benign, or malignant. Okay, now just touch on the two types of cell injury. So you get let me just see. Yeah, so you get reversible cell injury and irreversible cell injury. So with reversible cell injury, there's usually cellular swelling. Now, how does cellular swelling occur? So there's a decrease in ATP, decrease in activity of calcium and your ATP pumps, your sodium potassium pumps, your sodium potassium pumps, that leads to cellular swelling, okay? There's a decrease in protein synthesis, okay, because of the ribosomal detachment, there's plasma membrane changes, right? for example, bleeding. There's chromatin clumping, which is an example of nuclear changes. There's a rapid loss of function of the cell, and there's also myelin figures because of the aggregation of peroxidized lipids. Now, irreversible cell injury. Okay, there's a breakdown of plasma membrane, which leads to the release of cytosolic enzymes. Now, the word cytosolic enzymes, they basically leak outside of the cell, which basically results in the influx of calcium, and that activates degradative enzymes, okay, which now degrades those other normal cells and eventually the whole tissue. There's mitochondrial damage or dysfunction in irreversible cell injury. There's rupture of lysosomes, which leads to autolysis, so the cells automatically clean themselves. There's also nuclear degradation. Now, with nuclear degradation, you need to remember that you have nuclear condensation, which is called pagnosis. Then you also, which leads to nuclear fragmentation caused by endonuclease-mediated cleavage, and that's called karyorrhexis. And then that obviously leads to nuclear dissolution, which is karyolysis. So this is almost like the build up towards apoptosis, okay? So amorphous, the last point with irreversible injury is that is amorphous densitized. So
this thing is so
inclusion
smart. I can detect if there's another person in the room who overly. So it's like
hello. Somebody have a question? Okay, that's fine. Okay, cool. Okay, so let's go on. Yeah, so basically this is just how it looks, right? There's your normal cell. So the green arrows is for reversible cell injury. There's cellular swelling, ribosomal detachment, membranoblebling, nuclear chromatin clumping. The red is the irreversible, so there's all what I spoke about, and then obviously the unfortunate part is when it leads to necrosis, which is the death of the cell. Okay, so let's speak about apoptosis. There's some more information regarding apoptosis. I don't think you have to know this much information though. It's just like for interest purposes. I think the first paragraph is basically what you need to know, basically. So it's ATP dependent programmed cell death. There's three types of pathways. You get your intrinsic, your extrinsic, and your perforin or granzyme B pathways. Those pathways activate caspases, right? And those caspases leads to cellular breakdown, which includes cell shrinkage, chromatin condensation, membrane blebbing, and the formation of apoptotic bodies, which are then phagocytose. Now, the word phagocytose means to kill, okay? To kill, to break down, to engulf, okay? Phagocytose, G for gulf. So remember phagocytose, to engulf. Macrophages of the phagocytes, kill, hop on. So apoptosis is characterized by deeply eosinophilic cytoplasm and basophilic nucleus. It's very important to know the characteristics of apoptosis, right? So it's characterized by deeply eosinophilic cytoplasm and basophilic nucleus, pyknosis, karyorrhexis, right? Cell membrane typically remains intact without significant inflammation, unlike necrosis, right? So you need to understand the difference between apoptosis and the necrosis, okay? Then there's also DNA laddering, is a sensitive indicator of apoptosis. So that's more going into the the biochemistry of apoptosis. Okay, I'm not gonna actually go through the 3 types or pathways of apoptosis. Okay, but basically the intrinsic pathway is basically just occurs when the regulating factor is withdrawn from a proliferating cell population. The extrinsic pathway is basically these ligand receptor interactions. So there's like a external factor involved, which is the actual the interactions with the ligand receptor. And then for the perforin granules are involved is the release of granules containing perforin and granzyme B by immune cells, cytotoxic T cell and natural killer cell. Right, those are the 2 cells that shoot. They are killer cells, right? They destroy. Perforin forms a pore for granzyme B to enter the target cell. Okay, so that's basically just that. This is just an illustration of how apoptosis basically occur. So this is your normal cell. This is the intrinsic pathway. Don't think you need to know much now about the intrinsic pathway. There's an extrinsic pathway with your ligand involved. There's a cytotoxic T cell, which basically gonna help kill the cell because it's the body seeing it as a bad guy. Right? The body seeing it as a bad guy. Then the perforin, there's your perforins, right? There's your there's the passageway for the perforins to enter, right? There's that bleb which is formed. There's your apoptotic body, and then those apoptotic bodies is basically engulfed or phagocytosed by the macrophage. Okay. Now moving on to necrosis, right? So what is necrosis? Necrosis is an exogenous injury. So it's not endogenous, it's exogenous. It's like outside the actual cell. There's plasma membrane damage of the cell, right? And the cell undergoes enzymatic degradation and protein denaturation, and the intracellular components leak, right? And when that leaking occurs, there's a local inflammatory reaction, unlike apoptosis, right? With apoptosis, there's no like inflammatory response. It's just those 3 pathways: cytotoxic T cell, macrophage. But with necrosis, a whole other thing involved here. There's a whole inflammatory reaction, a local inflammatory reaction which occurs. Now, there's different types of, sorry, this is not actually, okay. So there are different types of, okay. There's different types of necrosis. Firstly, you get the agglutinative necrosis. It's seen in ischemia and infarcts in most tissues except the brain. It's due to ischemia or infarction, okay? What is ischemia? Basically, ischemia is a decrease in the, just remember, so it's a decrease in the nutrients, right? It's a decrease in the oxygen and nutrients that is provided to this to a certain cell, right? And ischemia leads to an infarction. Okay, the injury denatures the enzymes, and the proteolysis basically are blocked. Okay, so the cell obviously can't make any more proteins. I don't know if they went into histology, but here's just some notes on the histology as well for each of the different types of necrosis. So the main marker is basically there's a preserved cellular architecture, but the nuclei disappears, right? And there's increase in the cytoplasmic binding of the usine stain. So there's increase in the eosinophilia, right, which gives off a red or pink color. Liquefactive, so think of a liquid, think of pus. So think of bacterial abscesses or CNS infarcts, right? It's due to the neutrophils released lysosomal enzymes that digest the actual tissue. So on histology, in the early stages for liquefactive necrosis, there's cellular debris and macrophages. In the late stage, there's cystic spaces and cavitation. So think about it as neutrophils are like for the acute inflammation, macrophages going on later, macrophages causing cellular debris, and then later on you get the cavitation because now it's eating up and is causing a lot of cavities in those tissues, right? Caseous necrosis, very important, TB and systemic fungi, okay? It's due to macrophages that wall off the infecting microorganism, which leads to granular debris, right? So on histology, there's fragmented cells and debris surrounded by lymphocytes and macrophages, and that is known as a granuloma, okay? And that give you like a cheese-like gross appearance. So C for caseous and C for cheese-like gross appearance. Fat necrosis, it's seen in enzymatic. So you get two types of fat necrosis. You get enzymatic and non-enzymatic. For enzymatic, it's seen in acute pancreatitis, and non-enzymatic it's seen in traumatic. Okay. For example, injury to the breast tissue. Okay, it's due to damaged pancreatic cells releasing the lipase, which breaks down triglycerides. Liberated fatty acids bind calcium, which leads to saponification, which is like chalky white appearance. Okay, fat adipose generally is white, so that will be easy to remember. On histology, there's outlines of dead fat cells without peripheral nuclei. So there's no, because usually fat cells have a peripheral nuclei, right? But on histology for fat necrosis, there's no peripheral nuclei. There's saponification of fat combined with calcium. So you'll see that chalky white appearance. However, it appears dark blue on the H&E stain. Fibrinoid necrosis, that's seen in immune vascular reactions. You also get non-immune vascular reactions such as hypertensive emergencies or preeclampsia. Preeclampsia is basically hypertension in pregnant women. Okay, it's due to immune complex deposition. So I don't know how you can remember it, but think of fibrinoid as the I of the F's I, so I for fib and I for immune complex deposition. Seen in type 3 hypersensitive reaction and or plasma protein leakage from damaged vessels. Okay. It's on histology, the vessel walls contain eosinophilic layer of proteinaceous material. Okay, for gangrenous necrosis, very important to understand, especially for diabetic patients. It's seen in distal extremity and the GI tract after chronic ischemia. So long-term ischemia. Oh yes, you need to remember the difference between ischemia and hypoxia. Okay, hypoxia is a decrease in oxygen to the tissue. Ischemia is a decrease in oxygen and nutrients to the tissue. Okay, two types of gangrenous necrosis. Dry gangrene is due to ischemia. Wet gangrene is due to a superinfection, usually by bacteria. On histology for dry ischemia, you'll see coagulative necrosis. For wet gangrenous, on histology, you'll see a liquefactive superimposed on the coagulative necrosis. Okay, so that's basically just some images. I don't think they're going to give you images in the MCQ, but this is basically just for future purposes. If we're going to come back again to basically they're always going to revise this in each of the systems. You can always just come back and go over these images. Okay, I'm just gonna, can just take a 30-second breather. It feels like I'm going through a marathon. Okay, right. So let's go to ischemia. Right, so what is ischemia? Ischemia is inadequate blood supply to meet the demand. Okay, mechanisms include decrease in arterial perfusion. Example is arteriosclerosis. This could either be a decrease in venous drainage seen in this testicular torsion or Budd-Chiari syndrome. So Budd-Chiari syndrome is when the with regards to the GI tract. Okay, that's more, you're going to learn about that more when you do the GI system, and then also shock. Okay, um, so regions most vulnerable to hypoxic ischemia and subsequent infarction include the brain. So if you look at the brain, mostly it will be the anterior cerebral artery, the middle cerebral artery, as well as the posterior cerebral artery, the boundary areas. Okay, in the heart, the most common region is the subendocardium of the left ventricle, seen in this image over there. In the kidneys, the most common region for ischemia is the straight segment of the proximal tubule, also called basically at the medulla. Okay, and you can see there, it's like there's quite a little, there's not that much blood supply in that region. Okay, also in the thick ascending limb in the medulla. Then in the liver, basically around the central vein, most common basically regions for ischemia or infarction. And then in the colon, by the splenic flexure, there's basically less, basically high chance of ischemia infarction within. Watershed areas, you might have heard of watershed areas or border zones. So that is basically the areas over here which we spoke about in the brain. So that's your ACA, MCA watershed, and then this is your NCA, PCA watershed. It's basically with regards to the areas of the arteries and where they merge, okay? And then neurons most vulnerable to hypoxic ischemia includes Purkinje cells of the cerebellum, as well as pyramidal cells of the hippocampus and the neocortex. Now, there's two types of infarcts. You get red infarct as well as pale infarct. Okay, so red infarct occurs in venous occlusion and tissues with multiple blood supplies, right? For example, the liver, the lung, the intestine, and testes, and in tissues with reperfusion, right? Example, after angioplasty. Reperfusion injury is due to damage by free radicals. So free radicals, I'll basically just speak about, I think it's going to be in the next slide. For pale infarcts, it occurs in solid organs with a single endothelial blood supply. For example, the heart and the kidney. Okay, basically, what is free radical injury? So free radicals damage cells via membrane lipid peroxidation, protein modification, as well as DNA breakage. Okay, it's initiated via, for example, radiation exposure. You have inflammation, transition metals, metabolism of drugs, white blood white blood cell oxidative burst. Okay, free radicals, it can be eliminated by scavenging enzymes, right? Spontaneous decay can be eradicated by antioxidants, right, and certain metal carrier proteins. One example of free radical injuries, for example, oxygen toxicity. So too much oxygen is actually very bad. Okay, it can lead to retinopathy of prematurity in babies, abnormal vascularization, bronchopulmonary dysplasia in the lungs, and also reperfusion injury after thrombolytic therapy. I'm not going to mention a lot about ionizing radiation toxicity. This is just for interest's sake, but basically it's just that radiotherapy can basically, although it's good, although radiotherapy is very good for cancer, the thing is that ionizing radiation causes DNA and cellular damage, both directly and indirectly through the production of free radicals. And there are lots of complications which can occur, such as localized inflammation and fibrosis. Fibrosis is basically the hardening of cells. That's obviously after chronic inflammation, you get fibrosis, and then also neoplasia is actually quite a significant or complication of ionizing radiation toxicity. It's good. Radiotherapy is good because it damages cancer cells, right? But also, to a certain extent, also damage healthy cells. But the main, obviously, aim is to get rid of those cancer cells. Okay. Okay, types of calcification. There's two types of calcification: dystrophic calcification and metastatic calcification. So on the H&E stain, calcium deposits appear deeply basophilic, right? So in dystrophic calcification, there's deposition in abnormal or diseased tissues. Metastatic calcification is deposition in normal tissues, okay? For dystrophic, it's localized, whereas for metastatic, it's more widespread. Okay, associated conditions for dystrophic calcification is TB, as well as other granulomatous infections. Then you can just read that list over there. Associated conditions for metastatic calcification is predominantly in the interstitial tissues of kidney, lung, and gastric carcinoma. Okay, these tissues lose acid quickly, and the increase in the pH, right? The acidity favors, sorry, rather increase in pH. So obviously the alkalinity favors calcium deposition. Okay. The etiology or the cause of dystrophic calcification is secondary to injury or necrosis. That's why it's in abnormal or diseased tissues. The cause of metastatic calcification is secondary to hyperphosphatemia or hypercalcemia, okay? Which is more like a physiological response to a disease, such as chronic kidney disease or primary hyperparathyroidism, okay? Some mama bodies, you might come that later on in the year throughout one of the systems, but it's basically concentrically laminated calcified spherules. So that's all the deposition of the calcium, okay? It's usually seen in certain types of tumors, such as there's the acronym, please mom, don't forget the milk. Papillary thyroid carcinoma, meningioma, serous ovarian carcinoma, mesothelioma, and prolactinoma, okay? Milk. Okay, amyloidosis. Basically, what is amyloidosis? It's the extracellular deposition of protein in abnormal fibrillar form, okay? That leads to cell injury and apoptosis. So this deposition of this protein in this abnormal fibrillar form leads to cell injury and then eventually apoptosis. So the manifestations vary depending on the organ involved. So if it's in the kidney, it leads to a nephrotic syndrome. If it's in the heart, it leads to recessive cardiomyopathy. If it's in the GI tract, it leads to hepatosplenomegaly. In the brain, it leads to peripheral neuropathy in the nervous system. If it's in the muscle, it leads to muscle enlargement. That's why it's carpal tunnel syndrome, and so on. In the skin, waxy thickening, easy bruising. Okay. On the H&E stain, it's visualized by Congo red stain, as well. So amyloid deposits are visualized by Congo red stain. That's in image A. Okay. So on the Congo red stain, it's basically red or orange over here. And then in the H&E stain, it's amorphous pink. Okay. You get different types of amyloidosis. So primary amyloidosis is from Ig light chain. Secondary amyloidosis is serum amyloid A. So primary, remember, multiple myeloma. Secondary is in rheumatoid arthritis or inflammatory bowel disease. Then you also get transthyretin amyloidosis. I'm not going to mention all the others, that basically just for interesting, okay? Okay, moving, so now we're done with cellular injury. We're now going to move on to inflammation, okay? So what is inflammation? Just gonna take a water break. Okay, cool. So what is inflammation? Inflammation is a response to eliminate the initial cause of cell injury, to remove necrotic cells, right? To remove all that damaged cells, because the body doesn't want the damaged cells in the body. So the body wants to remove all that necrotic cells resulting from the original insult, and the body eventually wants to initiate tissue repair. Can be divided into acute and chronic inflammation. The inflammatory response itself can be harmful to the host if the reaction is excessive. So persistent inflammation can lead to something called a septic shock. Okay, what you need to remember about a septic shock is characteristics of a shock is a decrease in blood pressure, there's a decrease in your pulse. That's like the main features for shock. Okay, septic refers to the inflammation causing the shock. Okay, prolonged or inappropriate. Okay, so if the action is excessive, prolonged, inappropriate, it can be very, very harmful. Prolonged example is persistent infections such as TB or recurrent TB, and inappropriate inappropriate example is autoimmune disease such as SLE, lupus. Okay, we need to understand the mechanism of the signs of inflammation. So number one, you get redness and warmth, rubor and color. So basically vasodilation. So there's vasodilation of there's relaxation of the arterioles muscle, which increases the blood flow to that particular area. There are four particular mediators for rubor and color: histamine, prostaglandins, bradykinin, and nitrous oxide. Second sign is swelling, okay, or edema. So basically what you have to understand is that there's endothelial contraction or disruption from tissue damage, okay? So that increases the vascular permeability, so the vessels become more permeable basically to whatever is inside the vessel. There's leakage of protein-rich fluid from the postcapillary venules into the interstitial space. Maybe I should just draw something. Yeah, okay. So basically like that. That's like the vasodilation. Then that indicates the permeability of that all that protein. So from the postcapillary venules into the interstitial space, right? And that particular fluid, that protein-rich fluid, is what you call the exudate. Okay. There's now increase in the interstitial oncotic pressure. So interstitial is basically in this space over there. So there's increase in the interstitial oncotic pressure. So oncotic, if you ever hear the word oncotic, always think of protein. Okay, there's always protein. There's an increase like in the concentration of proteins. There's increase in interstitial oncotic pressure. Okay, endothelial contraction is mediated by leukotrienes, histamine, and serotonin. Then there's pain. Okay, so there's nerves everywhere in the body. So there's pain, sensitization of sensory nerve endings mediated by bradykinin, PGE2, as well as histamine. Okay. Lastly, loss of function. So inflammation impairs function, right? For example, inability to make fist due to hand cellulitis. Okay, so there's no function basically at that organ, because what happened at the tissue level affects what happens at the cellular level, affects what happens at the tissue level, which obviously affects the actual organ. Okay. Now, the systemic manifestations of inflammation. Okay, so we speak about the acute phase reaction. So acute is long term. Okay, and the body's now reacting to this, basically to whatever's happening in the body now, to this constant inflammation. So number one, fever. Okay, is the increase in temperature. So pyrogenes include macrophages. Pyrogenes induce macrophages to release IL-1 and TNF. IL-1 and TNF increase the COX activity in perivascular cells of the anterior hypothalamus. That increases the PGE, and that increases the temperature of the person. So that's just the mechanism of how temperature is increased in the body. Leukocytosis, there's an increase in the white blood cell count. Okay, the type of predominant cell depends on the inciting agent or injury. For example, if it's bacteria, there's an increase in neutrophils, predominantly neutrophils, right? And remember, neutrophils is in the acute inflammatory process. So acute phase action, bacteria, in the acute phase, neutrophils. Increase in plasma acute phase reactants. So serum concentration significantly change in response to acute and chronic inflammation. And
Sorry,
acute phase, yes.
may you please repeat that part of how there is an increase in temperature?
Okay. So the pyrogens, right, induce macrophages, right, to release IL-1, interleukin-1, as well as TNF. Okay. IL-1 and TNF, they increase the COX activity in perivascular cells of the anterior hypothalamus. So in the hypothalamus is found in the brain. Okay, so this is the brain. Okay, your hypothalamus is roundabout over here. Perivascular mean around the vessels of the brain. Okay, so right, so there's a kind of increase in the COX activity in perivascular cells of the anterior hypothalamus here in front, and that leads to increase in PGE2, which increases the temperature set point. So basically, this part of the brain basically controls or regulates your temperature, right? So what's happening is that there's a certain, basically, there are certain factors, for example, the pyrogens, right? Because of the inflammation, the pyrogens induce macrophages to release IL-1 and TNF, sends messages to the brain to increase the COX activity in the perivascular cells of the anterior hypothalamus. And at this point, right, what's happening here at this region is that there's an increase in PGE2, which increases the temperature set point. I just want to confirm what PGE means. I think it means prostaglandin, but I'm just going to confirm quickly. Basically, we don't need to know the mechanism too in depth, right? We just need to know like an overview, just like a basic understanding. But if you are interested, you obviously it's very, very good to obviously look into basically the mechanism of fever. Just gonna yeah, prostaglandin. PGE is prostaglandin. Yeah. Okay. Hope that answered your question. Okay, so I stopped by the acute phase reactants. So the acute phase reactants are produced by the liver, and they are notably induced by IL-6, interleukin 6. So interleukin 6, they induce the production of acute phase reactants. Okay. Here we go. So what are the acute phase reactants? So you get positive acute phase reactants as well as negative acute phase reactants. So the positive acute phase reactants, they basically upregulate your inflammatory response. Your negative acute phase reactions basically down-regulate your inflammatory response. Okay, so for example, C-reactive protein, the opsonin, right, fixes complement and facilitates phagocytosis, right? Phagocytosis is obviously the killing and the engulfing of the debris, okay, to get rid of the dead cells. And it's measured clinically as a non-specific sign of ongoing inflammation. Now, opsonin is basically this. Okay, opsonin is the whole process of, obviously, the whole process of, I'm sure you guys understand, but opsonin, I'm just gonna, I don't know if I forgot. Let me just double check quickly. I don't wanna mention the wrong thing. But I do know that the opsonin usually in after the chronic inflammation. Let me just double check. Yes, the antibodies or other supplementary binds foreign cells maybe more. Yes. So yes, so the C-reactive protein is basically responsible for opsonin, right? So opsonin is basically an antibody which binds to the microorganism, which facilitates the phagocytosis of that microorganism. So let's say, for example, this is the bacteria. So that's the bug, right? Opsonin, so the antibodies will bind to this bad guy. It will help the macrophage to actually engulf. So I like to remember this almost like it attaches to certain points, like it matches. Like obviously there's a whole interaction there, but this is obviously the facilitation of the phagocytosis, right, which will result in a killing of basically the degradation of that bacteria. Okay. Then we also have another acute phase reactant is ferritin, which binds and sequesters iron to inhibit microbial iron scavenging. There's fibrinogen for endothelial repair, haptoglobin, which protects against oxidative stress. We have hepcidin, which decreases iron absorption and decreases iron release. Obviously, that leads to anemia of chronic disease. We have procalcitonin, increases in bacterial infections, and serum amyloid A, which prolonged elevation can lead to secondary amyloidosis. Negative acute phase reactants, albumin. The reduction of albumin conserves amino acids. For positive reactants, because the amino acids, obviously via protein synthesis, will form like positive reactants. Transferrin is internalized by macrophages to sequester iron, and transthyretin, also called pre-albumin reduction, conserves amino acids for positive reactants as well. PCR, I'm not going to mention too much about this, but basically red blood cells normally remain separated by negative charges. Okay, products of inflammation, they coat red blood cells. So which means that there's now a decrease in the negative charge, and that leads to increase in red blood cell aggregation. So denser red blood cell aggregates fall at a faster rate with the pipette tube, and therefore increase in that erythrocyte sedimentation rate. That's increase in ESR, and it's often co-tested often with CRP, which is a more specific marker of inflammation. So the C-reactive protein is a more specific marker of inflammation, but usually they also use ESR, which is not that specific, but they also use ESR to also basically indicate whether this patient has an inflammatory, whether there's inflammation in this patient's body. Okay, so there's just some types of diseases where there's an increase in ESR, infections, inflammation, anemia, cancer, renal disease, and pregnancy. The decrease in ESR is sickle cell anemia, polycythemia, heart failure, microcytosis, and hypofibrinogenemia. Okay, and all of these, I'm seeing it as there's a decrease in the, almost like a decrease either in the integrity or the amount of red blood cells in your body. Okay, or the amount of active red blood cells. Okay, acute inflammation, this is where we need to be, all right? So there's acute inflammation and chronic inflammation. Acute inflammation is a transient and early response to injury or infection, okay? What are the characteristics? Neutrophils in the tissue, all right? As you can see, neutrophils are very purple, very dark purple, and it's often associated with edema, okay? It's rapid onset within seconds or minutes, and it's a very short duration. So it lasts for minutes to days. It represents a reaction of the innate immune system. So remember, the innate immune system is for the acute inflammation. Adaptive immune system usually represents the more into the going into the chronic inflammation. Okay, the innate immune system, it's a less that, like I said, it's a less specific response than chronic inflammation. Okay, the stimuli for acute inflammation are infections, trauma, necrosis, and foreign bodies. What are the mediators? Toll-like receptors, neutrophils, eosinophils, antibodies. So remember, there's both innate and adaptive immune responses in acute inflammation. It's just that the innate response predominates more in the acute inflammation. Okay, but I don't want to go into too much specifics into that. Okay, I think for now we just need to, it's just like an introduction. Okay, it's more of an introduction. We need to know what are the mediators. So the mediators are neutrophils. So if you hear the word neutrophil, we have to know, okay, it's acute inflammation. If you see the word macrophage, we need to know, okay, that's chronic inflammation. Okay, so some other mediators, mast cells, right? If you hear the word mast cells, basophils, complement. Okay, inflammasome, cytoplasmic protein complex that recognizes products of dead cells, microbial products and crystals, which leads to activation of IL-1 and inflammatory response. Okay, that's just what an inflammasome basically means. What are the components of acute inflammation? So you get vascular as well as cellular components. For the vascular components, there's a vasodilation, increase in the blood flow, and stasis of blood. Stasis of blood basically means that the blood basically, there's a decrease in the velocity of flow of the blood at that area. There's also increase in endothelial permeability. So it basically becomes more permeable. Okay, this contraction of endothelial cells opens the contraction of endothelial cells opens interendothelial junctions. Okay, for the cellular components, there's extravasation of the leukocytes. So the leukocytes now leak out, right? Mainly the neutrophils. Okay, from post-capillary venules, the accumulation of leukocytes at that point is basically leads to leukocyte activation. Okay, let me just see quickly the 4 steps of leukocyte extravasation. We'll speak on the next slide. What are the outcomes of acute inflammation? So the outcomes after the acute inflammation, there's the resolution and healing. There can be persistent acute inflammation. There could be an abscess formation, chronic inflammation, which there are antigen presentation by macrophages and other antigen presenting cells, such as the activation of CD4 T helper cells, and also scaring because of the healing that is basically occurring. Okay, now here's a point on macrophages. So macrophages predominate in the late stages of acute inflammation and influence outcome by secreting cytokines. So yes, it doesn't mean that, okay, because acute inflammation there's no macrophages. No, there are macrophages, but usually in the late stages. Leukocyte extravasation. The first step is margination and rolling, basically, of the, let me just see, margination and rolling of this particular leukocyte, right? Basically a white, basically the neutrophil, okay? So after that is tight binding and adhesion. Then there's migration, right? Transmigration across, right? Transmigration, and then there's the actual migration, okay? Through the gap, okay? Through the gap in the endothelium from the vessel lumen into the interstitium. So that causes the swelling, edema, okay? You don't have, I think all the others are just extra added stuff. Chronic inflammation. What is chronic inflammation? Prolonged inflammation is characterized by mononuclear infiltration, macrophages, lymphocytes, plasma cells, right? Remember, plasma cells is very important for the antibody production, okay? This leads to simultaneous tissue destruction and repair. Okay, so at the same time of destruction, there's repair as well. Angiogenesis is being included over here. Angiogenesis is the formation of new blood vessels and also fibrosis. So fibrosis is basically the deposition of fibrin or fibrinogen, and that's this hard connective type of, it's caused this hard type of issue to basically, it's basically just for healing, right? For wound healing. That's just basically my understanding of if I hear the word fibrosis, right? It may be preceded by acute inflammation. What is the stimulus for chronic inflammation? Persistent infections, which, for example, type 4 hypersensitivity, autoimmune diseases, prolonged exposure to toxic agents, as well as foreign material. What are the mediators for chronic inflammation? Again, macrophages, in the action of macrophages and T cells, chronic inflammation. So remember, Th1 cells secretes IFN gamma. What does IFN stand for? I think it's interferon something. Just forgot. Let me just double check. IFN gamma. Yeah, basically interferon. Yeah, interferon gamma, which leads to, or which is responsible for the macrophage classical activation, and that's like it initiates that pro-inflammatory response. Now, Th2 cells, they secrete IL-1, IL-13. That leads to macrophage alternative activation, and that's mainly for repair and anti-inflammatory. Okay, what are the outcomes of chronic inflammation? There's scarring, scar formation, amyloidosis, deposition of those proteins, as well as neoplastic transformation, right? It could be new cells to basically form to repair those, to repair the damaged tissue, okay? For example, you have a chronic HCV infection, right? HCV is a penicillin, which is it? No, wait. How am I forgetting HCV? It does cause this is weird, yeah. HCV infection. Yes, hepatitis C. Hepatitis C infection leads to chronic inflammation, right? Which can lead to an hepatocellular carcinoma, or you can have a Helicobacter pylori infection, which leads to a chronic gastritis, which leads to a gastric adenocarcinoma. So you can see the trend, right? You have an infection, then it leads to inflammation, Afterwards, it can lead to, sadly, it could lead to a neoplasia or a cancer. Okay, a little bit on wound healing. So wound healing is the healing of the wound after the chronic inflammation. What are the tissue mediators? FGF. So FGF simulates angiogenesis, the formation of blood vessels. TGF beta also for angiogenesis as well as fibrosis. VEGF simulates angiogenesis as well. PDGF is secreted by activated platelets and macrophages. They induce vascular remodeling, so remodeling of the vessels as well as smooth muscle cell migration. It also stimulates fibroblast growth with collagen synthesis. So the collagen is obviously all to help with the repair of that tissue. Tissue remodeling we spoke about, and then EGF simulates cell growth via tyrosine kinases. Now, what are the phases of wound healing? Right, there are three phases. In 1 to 3 days after the wound, there's the inflammatory phase. The effector cells are platelets, neutrophils, and macrophages. The characteristics is there's a formation of a clot, there's increase in the permeability of the blood vessels, there's neutrophil migration into the tissue, as well as the macrophages that clear the debris 2 days later, right, through the process of phagocytosis. Second step, from day 3 to about 2 weeks after the wound, okay? Proliferation. So the effector cells are fibroblasts, myofibroblasts, endothelial cells, keratinocytes, as well as macrophages. So remember, there's no neutrophils involved here. No neutrophils, no platelets in the proliferative phase. The characteristic is there's the deposition of granulation tissue and type 3 collagen, angiogenesis, epithelial cell proliferation, dissolution of the clot, and wound contraction. The contraction of those collagen through the help of collagen and the fibroblasts, right? The myofibroblasts. Then 1 week to 6+ months after the wound, there's remodeling. The effector cells is fibroblasts. The type 3 collagen is replaced by type 1 collagen to increase in the tensile strength of the actual tissue. Collagenasis break down type 3 collagen. Very important to understand that if a patient has zinc deficiency, there could be delayed wound healing. That's why we give zinc to increase wound healing. Granulomatous inflammation. So it's a pattern of chronic inflammation, can be induced by persistent T cell response to certain infections, such as TB, immune-mediated diseases, and foreign bodies. So the granulomas, they basically wall off a resistant stimulus without completely eradicating or degrading it. And that is obviously a result of persistent inflammation, okay? And that leads to fibrosis. Remember, the S in fibrosis, just think of it as stiff, right? Stiff and, yeah, rigid, stiff. And that leads to organ damage, because if the heart is stiff, the heart can't pump blood to the body, decrease in cardiac output, which leads to heart failure, okay? What is the histology of granulomatous inflammation? So the focus of epithelioid cells, basically they're activated macrophages with abundant pink cytoplasm that is surrounded by lymphocytes and multinucleated giant cells. Okay, the caseating aspect in the histology basically refers to that associated with central necrosis, and then the non-caseating type of the granulomatous inflammation is that there's no central necrosis. Okay, the mechanism, basically just quickly on the mechanism. So basically the antigen-presenting cells, they present antigens to the CD4 T helper cells, which secretes IL-12 right? And that IL-12 basically allows the CD4 TH cells to differentiate into TH1 cell. Okay, the TH1 secretes interferon gamma, right? As explained, I think it was in the previous slide before that, which is responsible for macrophage activation, right? This macrophage activation, right, increases the cytokine secretion, example TNF, and that is responsible for the formation of epithelioid macrophages as well as giant cells. Okay, so that's your granuloma. Causes of, okay, I'm just going to read this one. Anti-TNF therapy can cause sequestering of granulomas to break down. Okay, that's basically against that TNF over there, and that could lead to the disease to actually disseminate, because all this TB is in here. The TB is basically all protected in this granuloma, but if you have anything, if it breaks down, then it might disseminate. So always says for latent TB before starting anti-TNF therapy. You just see clear associated, so granulomatous inflammation associated with hypercalcemia due to increase in alpha hydroxylase hydroxylase activity, activated macrophages, resulting in increase in the vitamin D activity. Okay, I think that's probably basically just a small note over there regarding that. And then the causes for granulomatous inflammation is bacteria such as TB is the main one. There's fungal infections, parasitic infections, non-infection causes is immune mediated such as sarcoidosis, vasculitis, as well as foreign bodies. Scar formation. So scar formation basically it occurs when repair cannot be accomplished by cell regeneration alone. So non-regenerated cells secondary to severe acute or chronic injury are replaced by connective tissue. So the connective tissue has a role in the scar formation. Excess TGF-beta is associated with aberrant scarring such as hypertrophic and colloid scars. So two types of scars: hypertrophic, increase in size. So this increase in type 3 collagen, this parallel formation, and is confined to the borders of the original wound. It doesn't recur often and there's no predisposition. The colloid scar over here, this increase in type 1 and type 3 collagen is very disorganized. It extends beyond the borders of the original wound, frequent recurrence, and increasing incidence of people with darker skin. Neoplasia. So this is our last point under the fundamentals of pathology. Neoplasia. I'm not sure. I saw you guys did a lecture on carcinogenesis, so that's why I just decided to do a little bit basics on the neoplasia. But basically, carcinoma implies epithelial origin. Okay, sarcoma denotes mesenchymal origin, but both terms generally imply malignancy. Okay, cancer. So benign tumors versus malignant tumors. So benign tumors are well differentiated and well demarcated with low, with not as much cell division. There's no metastasis, no necrosis. But with malignant tumors, there's poor differentiation, erratic growth, local invasion, there's metastasis. Metastasis is obviously the transport of the cancer cells to other parts of the body, and there's a decrease in apoptosis as well. Okay, so the types, so basically the terminologies you have: benign and malignant. If it's in the epithelium, it's adenoma for benign, and then adenocarcinoma or papillary carcinoma for malignant. In the mesenchyme, get malignant blood cells, leukemia, lymphoma, in the blood vessels, and so on. Okay, for all the different types of cell types. The grade versus stage. The reason why I'm going through this just because it's gonna come up in the pathology lectures. So basically, to grade the tumor, you get low grade to high grade. The grading is basically the degree of the cell differentiation And the stage means the degree of the invasion and spread from the initial site. Okay, so that's all going to depend how far the tumor actually, like, how can I say, spread from the site of origin. Okay, so the T refers to the primary tumor size or invasion, the N refers to the regional lymph node metastasis, and the M is distant metastasis. So that's why they call it the T and M staging. Okay. The hallmarks of cancer, basically what makes cancer cancer, what makes cancer so dangerous, basically. So basically what I'm just going to say here is that cancer is caused by DNA mutations that affect fundamental cellular processes, right? So the growth signal cell sufficiency, so there's like mutations in genes encoding, for example, proto-oncogenes, right? Proto-oncogenes increase growth factors, right? The opposite of proto-oncogenes is like the tumor suppressor genes, right? That's anti-growth signal insensitivity, right? So mutations in the tumor suppressor genes. So tumor suppressor genes, genes that supposed to suppress the tumor, they don't suppress the tumor. So now there's an increase in the cell growth, or increase in the growth of the tumor, because there's no gene that's suppressing the tumor. Okay. Evasion of apoptosis. So now there's no apoptosis because now there's mutations in genes that regulate apoptosis. And now if there's no apoptosis, or if the apoptosis, the regulation mechanism is dysfunctional, then the body basically finds it difficult to kill off those cancer cells. Limitless replicative potential, basically that is the reactivation of telomerase. Okay. It's very quite tricky to understand this. I was also trying to understand this, but basically maintenance and lengthening of telomerase, which leads to the prevention of chromosome shortening and cell aging. Okay. Sustained angiogenesis, so that is the increase in pro-angiogenic factors to increase in the blood vessels. Okay. Warburg effect is a shift of glucose metabolism. Immune evasion in cancer. So normally immune cells can recognize and attack tumor cells, right? But for successful growth of the tumor cells, they evade the immune system. Basically, they escape the immune system. And there's a list of different ways on how they escape the immune system. Tissue invasion, so there's a loss of E-cadherin function, right, which holds the cells, for example, which holds, for example, the endothelium together, but now that leads to the loosening of intercellular junctions, and that also now leads to essentially vascular dissemination. Last but not least, metastasis. So tumor cells or emboli, they basically spread via the lymphatics or the blood. Okay, and that just explains how it basically spreads. Okay, so there's adhesion to the endothelium and then extravasation and honing of those metastatic cells, tumor cells, or the emboli. Just see quickly how far, because I need to go to immunology quickly. We'll hopefully end in about 15 minutes. Then I can open up for some questions. Okay, so basically common metastasis, you get metastasis to bone, to liver, the lung, as well as the brain. So those are basically regions in the body. That's most regions where most commonly you'll find your metastasis arising. Okay, most carcinomas spread via the lymphatics, and most sarcomas spread via the blood. Okay, hematogenously. Okay, this is just for interest purposes, but it's basically oncogenes. means that there's a gain of function mutation, which converts the proto-oncogene to an oncogene, and that increases the cancer risk. So that it increases the proliferation of your cancer cells. And some oncogenes which comes up a lot throughout the year is your BCR-ABL, responsible for CML and LL, and then MYC for Burkitt lymphoma, as well as BCL2 for B-cell lymphoma. Tumor suppressor gene is a loss of function, so increases the cancer risk. Okay, an example of that is the breast, ovarian, prostate, and pancreatic cancers, the BRCA1 and BRCA2. Then oncogenic microbes, so there's different viruses that can actually lead to the proliferation of tumor cells in different organ systems. Okay. Okay, I'm going to take questions at the end. There's just one more presentation that I would like to cover. Just one more presentation. But before the presentation, I'm just going to take a breather break, a water break, and then we can conclude with the fundamentals of immunology. Let me just see. Okay, cool. So just to end off with the fundamentals of immunology. So basically some key things to remember is the location of the immune cells, right? So in primary organs, so in the bone marrow, there's immune cell production and B cell maturation, right? In the thymus, there's T cell maturation, okay? Then you also get secondary organs. Secondary organs include spleen, lymph nodes, tonsils, Bayer's patches, which basically allows immune cells to interact with the antigens, okay? So a lymph node is basically a secondary lymphoid organ, right? That has many efferents, right? That has many afferents, one or more efferents, okay? It's encapsulated with the trabecula. And the functions are non-specific filtrations by macrophages, circulation of B and T cells, and immune response activation, okay? So the follicle is located over here in the outer cortex, and that's the site of B cell localization and proliferations, okay? You just see, and then the medulla. So the medulla consists of medullary cords and medullary sinuses. So the medullary cords over here, you see, right? They contain closely packed lymphocytes and plasma cells, and then the medullary sinuses over here, they basically contain reticular cells and macrophages. And the paracortex over here, paracortex contains T cells, okay? It's also the region of cortex between the follicles and the medulla. See, this is also just the lymphatic drainage association. So this basically give you your lymph node cluster in the first column, the area of the body where it drains from, and well as the associated pathology, which basically can lead, which basically where the the associated pathology associated with the metastasis of your whatever like bacteria or infection there is. Okay, about the spleen, I think more of this obviously going to learn further in the year, but basically a basic introduction. The periarteriolar lymphatic sheath, they contain the T cells and they're located within white pulp. The follicle contains B cells and they're located in the white pulp. The marginal zone, so the marginal zone, all right, they contain macrophages and specialized B cells, okay, and that's the site where antigen-presenting cells, they capture blood-borne antigens for recognition by the lymphocytes, and they're located between the red pulp and the white pulp. For the thymus, I think what's very important is just remember that T cells, thymus, B cells is made in the bone marrow, okay? And a thymoma basically means a neoplasm of the thymus. And it's usually associated with myasthenia gravis, superior vena cava syndrome, pure red cell aplasia, and Good syndrome. Okay, so innate versus adaptive immunity. So what are the components of innate immunity? So as we explained earlier on, it's neutrophils, macrophages, monocytes, dendritic cells, natural killer cells, complement, physical epithelial barriers, as well as secreted enzymes. In the adaptive immunity, components are T cells, so it's CD4, CD4 helper cells and CD8 cytotoxic cells, right? B cells, very important for antibody production, and obviously these are circulating antibodies from the plasma cells. So I think what they missed over here was in the adaptive immunity, they are okay, let me just see. Yeah, so in the adaptive immunity, there are plasma cells as well. Okay, the mechanism of innate immunity is germline encoded, and then adaptive immunity is a variation through recombination during lymphocyte development. So basically, let me just see. My understanding is basically innate immunity, the germ, the bacteria, it comes in and basically it presents an antigen, and we have our security guards basically fighting this particular bad guy. Now, the adaptive immunity, now these messages being sent, phone calls going out, let's call the police to come collect those people. The lymphocytes are like my police vans, gonna phagocytose, put them in the van, engulf, send them to the police, send them to the lymph nodes where they degrade to the lymph nodes, to the spleen, where they are degrade further. Response to pathogens. So innate immunity is non-specific, it occurs rapidly, there's no memory response. But for adaptive immunity is highly specific, it's refined over time, it varies over long periods, it has a memory response, right? And it's faster and more robust. That's why with vaccinations, the adaptive immunity plays a huge role with regards to vaccines, because that memory of that antigen is within our adaptive immunity, and the adaptive immunity plays a very important role in the role of us responding to vaccines. Secreted proteins in the innate immunity is lysozyme, complements, here the active protein as we spoke about, defenses by cytokines. In adaptive immunity, we have immunoglobulins as well as cytokines. Key features in pattern recognition with regards to innate immunity. So remember, there's toll-like receptors, which are responsible for pattern recognition receptors that recognize pattern-associated molecular patterns called PAMPs, right, and lead to activation of nitrogen inefficient. What is that now? Let me just check. Sorry. Um, Neurofibromatosis. Okay, it's interesting. Okay, but I think the main thing there is obviously the PAMPs, right? The pathogen associated molecular patterns lead to activation of neurofibromatosis. I think that probably can't make out that word over there. Okay, but it's fine. Examples of PAMPs include the LPS, so that's gram-negative bacteria, flagellin bacteria, as well as nucleic acids, okay, viruses. The key features in pattern recognition for the adaptive immunity, so memory cells, okay, these activated B and T cells, subsequent exposure to a previously encountered antigen, which basically will enhance a stronger, quicker um, immune response. Okay. Immune privilege, what is that? So organs and tissues where chemical or physical mechanisms that limit immune responses to foreign bodies to avoid damage that would occur from inflammatory sequelae. Okay. Major histocompatibility complex 1 and 2. So MHC encoded by the HLA genes, they present antigen fragments to T cells and bind T cell receptors. So you have MHC1 as well as MHC2. So the binding for MHC1 is for for TCR as well as CD8 killer cells, and MHC2 binds to TCR and CD4. So I remember the acronym, it's called 1824. So TH1, yeah, MHC1 binds to CD8 and MHC2 binds to CD4. So the structure is one long chain, one short chain in MHC1 and two equal length chains in MHC2. The expression of MHC1 is all nucleated cells, there's antigen-presenting cells and platelets, and then for MHC2 there's just antigen-presenting cells. The function for MHC1, it presents endogenous antigens, example viral cytotoxic proteins, to CD8 cytotoxic or killer T cells. The function of MHC2 presents exogenous antigens to CD4 helper cells. For the antigen loading for MHC1, the antigen peptides are loaded onto MHC1 in RER after delivery via TAP, transport associated with antigen processing. For MHC2, the antigen loaded following release of invariant chain in an acidified endosome. Associated proteins, I don't think that is relevant to remember, but basically just for MHC1, there's beta-2 microglobulin, and for MHC2, there's the invariant chain for the associated proteins. So this is basically how the structure for MHC1 looks. There's one long chain, one short chain, and then for MHC2, there's basically two equal length chains. So those are the functions for natural killer cells. Basically, lymphocyte member of the innate immune system. It uses perforins and granzymes to induce the apoptosis of infected cells as well as tumor cells. It's enhanced by mediators such as IL-1, IL-2, IL-12, interferon alpha, and interferon beta. Again, killing. They induce to kill when exposed to non-specific activation of signal or target cell and to an absence of an inhibitory signal such as MHC1 on target cell surface. Okay, just to wrap up. So it also kills antibody dependent, it kills via antibody dependent cell mediated cytotoxicity. Okay, we see DC16 binds the FC region of bound IgG, activating the NK cell. Okay, so antibody dependent, cell mediated. So the cell that mediates the killing of the antibody. Okay, major functions of B and T cells. So basically, B cells is for humoral immunity. The word humoral immunity is basically refers to the production of antibodies, okay? They present and present the antigen, undergo somatic hypermutation to optimize antigen specificity, production of the antibody, okay? They differentiate into plasma cells to secrete specific immunoglobulins, right? Which is the antibodies, and then they maintain immunologic memory. So memory B cells, right? They persist and they accelerate future response to the antigen. For T cells, it's for cell-mediated immunity. So that's basically with the release of cytokines, right? So CD4 T helper cells, CD4 T cells, they help B cells make antibodies, and they also produce cytokines to recruit the phagocytes to the site of the inflammation, and they activate other white blood cells. CD4 T cells, they kill directly, right? They kill virus infected and tumor cells by perforin and granzymes, similar to NK cells. So here's a rule of 8. This is how they give it on how to remember the thing. So 2 times 4 is 8 and 1 times 8 is also 8. That's a nice way to remember which MHC class goes with which T cell. Okay, the respective T cell. Differentiation of T cells. So this is very important, especially throughout the entire through all the systems when you're going to do immunology. This is actually an exam question. If you like know this, you know, you know a lot if you know this slide, especially for T cells. So you have your T cell precursor differentiating the thymus into CD4 and CD4/8. In the medulla, it separates. Okay, remember CD8 is a killer, CD4 is a helper. In the lymph node, there is different, basically, I think of this almost like as messages or transporters, okay? Cytokines, right? All the different cytokines, which basically allows the differentiation of the helper cells into Th1, Th2, Th17, and T regulatory. So they secrete those cytokines, and the function of Th1 is to activate macrophages and cytotoxic T cells. Function of Th2 is to activate eosinophils and increase in the IgE antibodies. The function of Th17 is to induce neutrophilic infiltration, and the function of T regulatory cells is to prevent autoimmunity, basically to maintain tolerance as well. Positive and negative selection. So basically positive selection happens in the thymic cortex, right? Double positive T cells expressing TCRs capable of binding self-MHC on cortical epithelial cells survive. Okay, so cells that are basically able to express THCRs, right? These are receptors capable of binding to the MHC, they survive. So that's a positive selection. It's almost like in grade 12 we learned about the natural selections. That's almost like the positive selection. So that's positive selection. Negative selection happens in the thymic medulla. So T cells expressing T cell receptors with high affinity for self-antigens undergo apoptosis, right? So if the receptors on the T cell, if they have high affinity for self-antigen, it's very bad for the body because it's going to want to kill the body. It's going to want to kill itself, basically, and that's where autoimmunity comes in. So those T cells, they undergo apoptosis, they die off, or they basically become regulatory T cells, and that's called negative selection. But you'll learn more about this in another lecture, okay? That's just a basic introduction. Macrophage lymphocyte interaction. So that's the interaction between, so Th1 cells, they secrete interferon, which enables the ability of the monocytes and macrophages to kill microbes that they ingest. So you need to understand the interaction between the macrophage as well as your T helper cell, right? This function is enhanced by interaction of the T cell CD40L with CD40 on macrophages. Macrophages also activate lymphocytes via antigen presentation, so they kind of help each other. Cytotoxic T cells, okay, we spoke about that. They kill virus infected cells, neoplastic and donor graft cells by inducing apoptosis. They release cytotoxic granules containing preformed proteins. Cytotoxic Cytotoxic T cells have CD8, which binds to MHC1 on virus-infected cells. What are regulatory T cells? They help maintain specific immune tolerance. That's a very, very important word, immune tolerance, right? Is our body able to tolerate the actual immune, is our body able to withhold or have the capacity to withstand those immune processes that is happening, right? By suppressing CD4 and CD8 T cells, effective function. So the regulatory T cells, they regulate so that there's not too much um, cytokines, so that it prevents a cytokine storm from happening from the CD4, and it also prevents the CD8 killer cells to kill too much cells. So that's how the regulatory T cells regulate basically the whole process that's actually happening. Okay. Um, it's activated by regulated T cells. So activated T reg cells, they produce anti-inflammatory cytokines. So anti-inflammation is actually very important. Yes, inflammation is good, but anti-inflammation is also vital because the body can only withstand that amount of inflammation. Okay. So this is just a basic diagram, basic explanation for T and B cell activation. So for T cell activation, you're always going to have an antigen presenting cell, which presents the antigen to your T helper cell, right? So different APCs are B cells, dendritic cells, Langerhans cells, as well as macrophages. Two signals are required for T cell activation, B cell activation, and class switching. Okay. So for T cell activation, there you go. Antigen-presenting cells via MHC2 brings it attaches to the T cell receptor. Right. There's your CD4. CD4 could either be the CD4 or CD8 cell, depending. So remember, remember it was 1824, right? Yeah. So remember 1824. So the MHC2 will bind obviously to the CD4, and then the MHC1 will bind to the CD8. Okay. Then that information will be sent right to the naive. That's obviously the naive T cell. It now knows that there's an antigen. Now it basically send information. It basically now this month basically my understanding is that it now have the message that is the antigen. So now there's activated T cell actions which now occur. So now there's increase in the cytokines which now basically call on other cells to come to the party. Okay, so that's basically what's happening. For B cell activation and class switching, basically what happens here is that you have your activated CD4 T cell. It's going to bind to the MHC class 2. It has a T cell receptor carrying that antigen over there. Okay. It sends over the information. My understanding of this over here, this and this, right? This over here, it's basically just for signaling. Okay. It's proliferation and survival, right? It's co-stimulatory signaling via those things, right? So on the dendritic cell, there's that one, and on the naive T cell, there's that one, right? That's just for the survival. It's just like almost like there to help send the signal, okay? So and you can see over here, right, that this is just obviously here. It's just obviously for proliferation and survival, like survival purposes. Okay, so that is over the information. There's binding occurring over there. This activated T cell releases the cytokines. So cytokines like chemo messages, right? There's my understanding of sending the messages. Th cells secrete cytokines that determine Ig class switching of B cell. So these cytokines send messages to the B cell, which basically now needs to determine which class of antibody should now be formed. Okay, should now be made. So over there's your antigen there as well, going onto your B cell receptor. Okay, at the end of everything, there's activated B cell actions, which obviously is now going to form the antibody. Okay, so B cells are activated and they produce the immunoglobulin. Okay, essentially which is the antibodies. So this is basically the structure of the antibodies. So the Fab fragment consisting of like heavy chains recognizes the antigens. So the FC region of IgM and IgG fixes complement heavy chain. The heavy chain contributes to FC and Fab regions. The light chain contributes only to the Fab region. Okay, neutralization means that the antibody prevents the bacterial adherence. Opsonization is that the antibody promotes phagocytosis. Opsonization is almost like a coats it with marinates that the antigen, and then complement activation is complement goes on the, how can I say, complement basically also like goes on that the antigen, and then it basically enhances opsonization and the killing of that antigen basically. Okay, and then on there you also have something called a membrane attack complex. Okay, immunoglobulin isotypes, so basically there's IgG, IgA, IgM, IgD, and IgE. Okay, so IgG greets the growing fetus. So it's associated with warm autoimmune hemolytic anemia. It's the main antibody in the secondary response to an antigen. Okay. IgA prevents the attachment of bacteria and viruses to the mucous membranes. Okay. It does not fix complement. IgM is the first antibody to be produced after an immune response. Okay, so IgM is the first. Okay, which you see over here, and then IgD expressed on the surface of mature naive B cells, normally low levels of detectable in serum, and then the IgE, it binds mast cells as well as eosinophils. Okay, but more of this obviously will be dealt with further in the year. You see over here, this is just regarding antigen type and memory. So you get thymus dependent antigen, thymus independent antigens, and then here's just some more information regarding the complement. Okay, so complement system of pathically synthesized plasma proteins play a role in the innate immunity as well as inflammation. So the membrane attack complex defends against gram-negative bacteria. Okay. There's activation pathways. So the classic is the IgM or IgG or IgM mediated pathway. Okay. So there's different functions of different complements. So opsonization, anaphylaxis, neutrophil chemotaxis, which is the transport of the neutrophils, and then cytolysis. Okay, let me just see. Okay, opsonins and as well as inhibitors. So opsonins, they help, they enhance the phagocytosis, they help the killing. So opsonin to prepare for eating, and then inhibitors, they basically prevent complement activation on cells. That's like the opposite of complement. Then this is just important cytokines that we kind of spoke about. Over here is a nice thing to remember: hot T-bone steak. So R1 is for fever, hot. So R1 is a cytokine causing hotness or fever. R2 stimulates T cells. R3 stimulates bone marrow. R4 stimulates IgE production. R5 stimulates IgA production. IgE stimulates an acute phase protein reaction. And the other interleukins as well. So these interleukins secreted by macrophages. The cytokines are secreted by T cells. These cytokines secreted from Th1 helper cells and also from Th2 cells. Passive and active immunity. The main difference between that is that with passive immunity, it's receiving preformed antibodies. Okay, receiving of preformed antibodies. So we just see, for example, IgA in breast milk. So for example, a baby feeds on the mother, it gets preformed antibodies from the mother, and now the body can use those antibodies against other antigens. Active immunity is an active process, so it's exposure to exogenous antigens. So it's now our body actually actively producing our own antibodies to actually fight off the respective antigen which is produced to our immune system, right? So our immune system is aware of those antigens. Some more information on different types of hypersensitivity reactions. So there are 4 types. Basically, anaphylactic and atopic, type 1. Antibody mediated is type 2. Immune complex mediated, type 3. Delayed or cell mediated is type 4. Okay, so it explains to you beautifully over here the phases of the type 1 hypersensitivity. So that's anaphylactic and atopic. So that's like your R cells, immediate degranulation, histamine in the early stages, in the late stages, inflammation and tissue damage. Okay. Type 2 hypersensitivity, it's antibody mediated, right? Antibodies bind to cell surface antigen or cellular matrix, leads to cellular destruction, inflammation, and cellular dysfunction. Okay. Okay. Type 3 hypersensitivity reaction, it's immune complex antigen antibody mediated. Okay. It attracts neutrophils, and the neutrophils release lysosomal enzymes which kills off whatever the bug or the germ is. Okay, it's associated with vasculitis as well as systemic manifestations. For hypersensitivity reactions, 2 mechanisms, each involving T cells. Right? Remember, this type is cell mediated. Okay, so the direct cell cytotoxicity, CD8, they kill targeted cells, right? That's direct cell cytotoxicity. The inflammatory reaction, where the CD4 T cells, they recognize the antigen and they release inflammatory inducing cytokines, which calls up all the other killer cells to actually fight off this particular antigen. We've reached the end of the LAM revision session. Thank you everybody for joining in. I don't know if there are any questions. Let me just go to the where is that now? Yeah, okay, so I hope it was of a benefit. I know that there's a lot of work. It's a lot of concepts, lot of theory, but very important. Try to filter out the main stuff, filter out what is very important, And in second year, try to already imagine the patient in front of you, right? Try to now think about diseases, think about what are you going to look, what signs and symptoms are you going to develop into specific diseases, okay? So yeah, thank you everybody for joining in. Have a lovely rest. Have a lovely day of last day of studying before the LOM. The LOM is only about, if not mistaken, 5%. So don't stress too much, but generally it's very doable. It's very doable. Questions are not that complex. So yeah, you guys will do great. Okay. I'll send a present to the group chat. It's a set of MCQ questions for LOM that I found in my drive somewhere. I eventually found it. Clara found it, so I'll send that in the group as well. Cheers, everybody.